Hello and welcome. Post-COVID-19, the importance of public health systems, administration, and policy has never been so starkly highlighted. Equally, as we grapple with the challenges of scale and reach, the challenge of public health financing will also be felt in as much as administering it, but also the new tools and the administrative, perhaps, innovation that we need to ensure that health or healthcare access reaches the people who need it the most. So that's the big challenge ahead. So to discuss what public health finance means and how it will or can be administered in a way that is more effective going forward, including, of course, the lessons that we've learned from COVID-19, I'm now joined by Sujatha Rao, former Secretary of Health and Family Welfare, Government of India. Ms. Rao, thank you very much for joining us. So let me ask you a very simple question first. You know, we all access some form of healthcare or the other, either in the private space or the not private space. So where does public health finance come in? And when people say that, you know, India spends a very low percentage of its GDP on health, which is less than 2%, what do they mean?
Well, you know, all expenditures that are incurred on health, direct and indirect, which are spent by households, by a private sector setting up a hospital, or by government which implements programs where they give drugs, they set up hospitals like AIMS, and so on. All this expenditure is what constitutes the total health expenditure. And it is normally believed that at least a country, to get a reasonable quality of healthcare, should be spending at least 5% of its GDP, of which a majority of it should be public health financing, which means the government which pays out of its taxes that it collects from its revenue. So that is normally the only outlier, of course, here is United States. But even in US, 50% of the total health expenditures is incurred by the government through their various government programs. So it's not all private sector.
Right. So
here, when we say that we need to spend more, India has been chronically, right from the beginning, has been spending about 0.9 to 1.2% of its GDP. It has never gone beyond that. Sometimes water and expenditures incurred on sanitation are also included because they do have health outcomes. And so they raise it up to saying we are spending 1.4. But in reality, if we just were to take the total health spending incurred by Government of India, Ministry of Health, Railways, Defense, Labor, all these are departments also who spend on health for their own target groups. And complemented by the state governments which also spend. If you put all this together, like last year, we spent 1.15% of our GDP. And there are only less than 15% of the 15 countries in the world which have spent less than 1 or 1.2% of GDP. And we are one of those 15 countries. It's extremely low. And that's the reason why most of the expenditures are incurred by out-of-pocket expenditures. That means people are paying for the healthcare. And so they say that health security in India is extremely low.
Right. So you talked about the total expenditure on health. So when we say, for instance, that the private sector represents almost 80% of India's healthcare sector. So does that mean in terms of expenditure as well?
No. Private sector, private sector also means private sector healthcare givers. That's the hospitals and those who are providing service. It also means households. Like I go to a quack and I buy some drugs from him, or I go to a solo practitioner, or go to a pharmacy shop, buy drugs, or go to a diagnostic center and get an X-ray done. All that comes under the private sector spending. So if you say private sector expenditure is 69% of the total health expenditures, that is right, in the sense it's households who are spending the money, because more than half of this is going just on diagnostics and medicines. So it is believed that if government were to intervene just on those two, the out-of-pocket expenditures, as we call it, or private expenditures would reduce. So there are two aspects to the private health expenditures. One spent by the healthcare givers in the private sector, and the other by households taking the services by paying for them.
Right. Now, you said that, this is a sector or area that's been chronically underfunded, and maybe that's not likely to change now, or it won't change so soon. But if you were to look at COVID-19 and what we've been experiencing in the last 4 or 5 months, what are the stark insights which should tell us how or where maybe things could have been better or different if we had more, let's say, investment in public health?
The COVID-19 has more than any other disease program that we faced, has really put in stark focus the importance of health. I mean, what a damage health can do. Look at our GDP, it's kind of plummeting down. That's the impact of infectious diseases and communicable diseases that have. And all systems and all countries are vulnerable to such an attack. And so, therefore, there is a constant vigil that we need to have. And it is very important to keep on investing on basic healthcare and basic surveillance systems, basic public health functions, which are imperatively an imperative function of the government, because it's population health. It's not something that you can leave it to a private sector to incur those expenditures. The reason why I would say that, compared to other countries, India has not done well on COVID is, apart from several other, you might find shortcomings in decision making, is that our health system is so fragile. We have not invested enough because of this chronic low public spending. We have not spent enough on public health. We have not spent enough on primary care. We have not spent enough on communicable disease control programs. In fact, the last 3-4 years, if you look at the budgets, we've been reducing our expenditures on TB, malaria, and other infectious diseases in proportion to the total amount that has been allocated for health. So the disease surveillance has been a weak point. So when COVID hit, it has hit us very badly, because we just we're not even able to afford enough test kits to make it available for anyone on demand. We don't have adequate laboratories. I mean, the whole delay for 2 months, March and April, we wasted because we didn't have the kits and we didn't have the laboratories to test those kits. So we were so weakly prepared, so poorly prepared, is largely because we've never invested enough public health infrastructure.
So, just for contrast, I mean, for someone who's watching this now, countries like Italy, United Kingdom, or even the United States right now are also facing a huge attack on their healthcare systems and have been overwhelmed. We've seen, images and reports from New York City, for instance. Now, these are countries, if I were to look at it as a layperson, which seem to have some of the best healthcare or healthcare systems for other reasons, including reasons being that they are developed countries and they're first world countries. So why is it that these countries have also suffered, and while we are underfunded or underinvested, maybe not so badly off at this point of time?
Okay, you've mentioned 3 countries, and that's a good sample to take. In Italy, if you remember, it was sheer carelessness. They allowed the Chinese from Wuhan to keep coming. They didn't control and block the borders the way Australia and New Zealand did in time. And therefore, once it caught on, it really caught on badly. And it was, in fact, in Italy itself, the province which was most affected is also the largest number of the very elderly. That's 80, 85-year-olds. So there was a demographic angle to Italy, and their initial carelessness in taking appropriate decisions of closing down their borders. Where UK was concerned, also they were in denial. If you remember, for a long time, the Prime Minister kept on talking about herd immunity will be the way to go. There's no need to do any lockdowns. There's no need to take any precautionary measures and so on. But having recognized the problem, today you see they are much more controlled, much better performance and outcomes after they decided to act in, as compared to US. US has run away largely because they just have never invested enough in preventive and primary health care. There's all been hospital-based, insurance-based, hospital care-driven health system. You fall sick, I cure you, but their own preventive and promotive healthcare, which falls into the spectrum of primary care has always been a problem in United States. And public health
Right.
is something they never really paid much attention to. Over and above that, of course, is the fact that, the leadership made lots of, I mean, that's another discussion, I know, and we probably don't want to go down that road. But essentially, it was also poor leadership. They didn't allow CDC, and it's not as if America lacked the expertise and didn't know where they were going. It was just that there was a lot of other political considerations
Right.
stepped in and made a mess.
Right. So, to come back to finance, I mean, you said that we've never gone beyond 1.2% in the real sense, if you were to look at sharp healthcare financing. Now, if you were to look ahead, including from some of the lessons that COVID has given us, maybe to invest more in, as you said, on surveillance, maybe in terms of community healthcare and in community healthcare infrastructure. So where do you think we can bring in that money from, and what kind of money are we talking about? That's the first question. Secondly, can the government better focus on improving access to finance or improving access to healthcare, or both?
This is a moment which is very tragic, because this is a time when we really, really ought to be investing huge amounts of money on health and really double the money to 2.5 or 3% of the GDP, so that we really give it the necessary push that it requires. But there's also the time when you know better than me how badly the economy is off. So it is not possible. It's just not only the public finance which is in deep trouble, but it is also the private sector for investment. They have lost a lot during the lockdown, where they could not operate their hospitals, and now they are stuck with COVID cases only. With the results there, they get limited amount of money. So they are also in a financial crisis. It's not as if the private sector is sitting with mountains of money, which they can, which with a few incentive and appropriate policy frameworks, they could go and invest in health. So it is a very tight situation we're in. And I would say that given this moment and this moment of crisis, government should sit down to very clearly reprioritize their spending that they've been doing so far. Not that there is much room, but whatever little room that they have, because, even as I speak today, the entire budget, much of it, majority of it is going towards buying test kits and setting up laboratories and for COVID management. Not their own regular programs like immunization and all have had to, for besides other reasons, also funding has taken a hit. So therefore, given this little money that they have at their disposal, they may have to reprioritize, may have to look for more reliable and also less costly options by engaging more community and task shifting to nurses. This kind of re-strategizing the entire human resources and technologies that we have and the health system to make it a much more affordable.
Right. And I'm going to come to technology in a moment. So if you had the clean slate in front of you and said, okay, you can go from 1.2 to let's say 2% of GDP, which is also obviously tens of thousands of crores, what would your first and primary focus be? Where would you actually spend that money for the impact that you would desire?
I would spend it immediately on the primary healthcare system, because that's so badly, the infrastructure, the manpower and all that. You have to realize that even when Ebola struck Sierra Leone and Liberia, and where they lost GDP by more than 5 to 10% percentage points, it was not the $1 billion aid that came from abroad to set up hospitals that helped them go over the crisis. It was a community participation and community-led efforts that helped them to overcome the Ebola crisis. So infectious diseases and pandemics, which hurt so much, require community participation. I would really spend on bringing in behavior change. And all these are done in the primary care space. They're not done by AIMS. They're not done by Hindujas. They're done at the community level, and that requires a lot of money. So I would say that I would fill up the vacancies. I would spend money on training. I would spend money on seeing that the people get access to healthcare, and get ramp up my entire primary healthcare. Even in terms of bed capacity, you have to realize that as we speak today, Bihar has, I think, every 7,000 people or 14,000 people, if I remember correctly, have access to one bed. That's not something that's going to help us if the COVID goes into the rural areas. So it's very critical that we get our primary care and district hospitals into shape before we get on to other investments. And where would I get this? I would co-opt my small and medium nursing homes, which are in the private sector. They are there, they've made the investment. I would negotiate a fair rate with them, and I would seek them also to work with the government so that together we ramp up the capacity much faster than if I were to go alone in working with the government alone.
So therefore, you're saying that the capacity is there, particularly at the primary healthcare center level, but or at the rural or district level, but it's more about using or co-opting the capacity, which is more important.
In the private sector, we are not co-opting the small and nursing homes as effectively as we should. But I think with a little few incentives, they can be brought up to the standards, minimum standards that we'd like to enforce, and they could become good partners at the field level.
And that you feel would, to some extent, ameliorate the problem, of healthcare access?
Yes. I would not look at, what I mean is I wouldn't want to look at Apollos or corporate sector hospitals, in that sense, because they're just 3 to 4% of the whole private sector. They're not the major players in this game. Of course, unless you need oxygen and ventilators, that's a tertiary care treatment, that's separate. But basic healthcare, it's the basic doctors are really both in the private and the public sector, and I would use them much more intensively and imaginatively. What we need today is imagination, not just only money. But I think the leap has to come by imagining on real data.
Right. So if you were to now look at finance from the personal side, there are, insurance is obviously one way to protect a citizen or, anyone who could unfortunately face a healthcare situation. Now, is that something that we can, I'm sure we have a system, but can we improve that? So healthcare access is one challenge and funding that. But on the other hand, funding the ability of a citizen to be ready for a dramatic healthcare situation?
Well, in that sense, if you notice, the government has done quite well in spreading the health security net across the poor people, whether through Ayushman Bharat or whether the state-run health insurance programs. So to that extent, like in Andhra Pradesh, 90% of the people, not just the poor, 90% of the people are covered with insurance for 2-3 lakhs of rupees, and that's ample amount of money if you really mean in terms of providing basic and secondary healthcare or even some procedures in the tertiary care. So that is there. But again, what really happens is that we are not paying promptly, and the private sector doesn't have those deep pockets to wait for 1 year for you to repay the money that they have, the claims that they have submitted to you. So overall, the investment has to increase, whatever you might say. So if you want insurance to come in, it's a good system. Like in Kerala, they've used this demand side financing to improve their own, ramp up their own supply side. That kind of creative use can be made. But whatever, even if we were to use that route, we would still need some money to be able to pay off those private sector providers. So there is a bottom line that you have to increase your overall public investment.
Right. So now the role of technology, whether it's technology in conjunction with finance or technology in conjunction with health, how can all that maybe make things simpler and maybe make, have sort of give us a better bang for the buck?
Sorry, technology and?
In conjunction with finance. So for instance, better ways of either offering insurance products, using technology and delivering it, on mobile phones, and similarly technology in health, which is really, more long distance medicine, telemedicine, and all of that. So my question is, can all of these really simplify or provide a better bang for the buck?
Technology certainly can, particularly telemedicine has huge potential. Not all of it, but the boundaries have really been blurred with technology because you can get access to a specialist sitting 300 miles away. And that's a huge step forward. So I would say technology, not only giving iPads to a health worker in the villages, but using more of this for rapid diagnostic kits, which can be then used in the village level, using telemedicine to get access to a specialist consultation in time. All these are cost saving, quick diagnosis is possible, and better treatment outcomes are possible therefore. So I would say that technology along with public financed health insurance could be a real big bang for the buck, because people don't have to then spend money out of their own pocket shopping with hospitals or going to diagnostics and getting unnecessary tests done and buying unnecessary drugs and so on. So
Right.
the spending has to be on drugs, diagnostics, and technology which gives you access to healthcare.
Right. So if you were to now, if I were to ask you about trust, so while let's say, let's assume that we do increase spending, the spending finds its way into better primary care facilities at the rural district levels. We are able to maybe augment capacity, as you pointed out, in working with the private sector, taking some beds maybe in every zone. So we're getting all of that. How do you build more trust? And how do you build trust within the public, in the public health system?
Wherever we have delivered good quality care, there has been a trust. All said and done, I know that there is so much of cynicism on government programs, but just think about it. Malaria, TB, HIV, AIDS, maternal and infant care, all these are provided by the government free of cost to every citizen in the country. Immunization for 12 vaccine preventable diseases is in the public domain, free of cost for every citizen. So, the public sector with its little resources is doing quite a lot if you really come to think of it. It only means that it requires a further 1% more for capital infrastructure and for appointing the key personnel in all the facilities as required. This is where we are running short. So when there is a reliability of supply of services, people will come. But if you have a facility and you don't have a doctor, you don't have drugs, how does the trust then develop, So I think these are budget bound. You increase finances, develop the system, and people will come. There is no doubt in my mind at all.
Okay, build them and they'll come. Mr. We're running out of time. Last question. So, you've held the position of Health Secretary, but you're also deeply interested in the subject. And you've also written a book after that. Tell us one instance or maybe two that, give you confidence in what public health can deliver and why people should trust it. And this is, something that you've either experienced or you've seen in your many travels.
I think I've been very fortunate of being directly involved with both HIV, AIDS, and polio eradication. And these are the two biggest public health,
Initiatives.
Yes, in the country. And so we are the one country which had the highest fall in incidence of HIV, AIDS, which still doesn't have a cure in the world. We brought it down by 70% of incidence in HIV AIDS, and it was a homegrown strategy. It was something that, we have about today 10 million people on ART drugs. So I think it's a remarkable achievement which we can really be proud of. And eradicating polio is not small. Can you imagine the number of millions of children on a single day at a particular time getting a vaccine shot? I think it's a remarkable achievement. And that indicates the breadth and the depth to which the span of operations that a government can really reach out to. No private sector or no one can achieve what a government can and has demonstrated in both these programs. I think we have the knowledge, we have the experience, we have the ability and the capacity in India. We need not have done so badly on COVID as we have if we had utilized all this experience. I'm afraid I have to end on this note, but I really think India is not second to none in terms of being able to handle infectious disease or a public health problem. It's only that we've neglected it so long that neglect has its own consequences. And that's what we're seeing today.
Right. Mr. Rao, thank you so much for joining me and sharing your thoughts and insights. And I do hope that in coming union budgets, when the finance minister rises, we will see fresh and new allocations, which will hopefully achieve some of those points that you've talked about. Thank you so much for joining me.
Thank you for having me. Thank you.